Acne Keloidalis Nuchae is a persistent folliculitis of the back of the neck with keloid scars and cicatricial alopecia. The exact etiology of Acne Keloidalis Nuchae is still unclear. We know that there are certain triggers that may start the disease, including chronic irritation, cutting the hair very short, friction, heat, and humidity, leading to a state of repeated folliculitis. Another theory states that Acne Keloidalis Nuchae is an autoimmune reaction towards an unknown follicular antigen, or it may be towards a perifollicular antigen, for example, Demodex, skin flora, dyschromatic keratinocytes, and sebum or hair cosmetics. There are several reports of iatrogenic Acne Keloidalis Nuchae with cyclosporin, diphenylhydantoin, and carbamazepine. Secondary infection with Staphylococcus aureus and malassezia may exacerbate the condition, but on their own, they are not a cause of Acne Keloidalis Nuchae. Whatever the etiological factors are, the eventual outcome is an acute perifollicular inflammation that weakens the follicular wall at the level of the infundibulum, the isthmus, or both. The follicular wall then breaks, and naked hair shafts are released into the surrounding tissue, which is recognized by the immune cells as a foreign body, leading to a reactive perifollicular granuloma. The fibroblasts react by producing new collagen and leading to fibrosis that distorts and occludes the follicular lumen. Clinically, Acne Keloidalis Nuchae starts with a firm, dome-shaped inflammatory papule and occasionally pustules. Over the back of the neck, the papules then coalesce and form a keloid-like scar. The main differential diagnosis for Acne Keloidalis Nuchae is folliculitis decalvans, which shows less fibrosis and keloid formation and more pustules than Acne Keloidalis Nuchae. The other differential diagnosis is the perifolliculitis capitis absidens esophageans, where in this disease we see nodules, pseudocyst, interconnecting sinuses, and abscess formation. Treatment of Acne Keloidalis Nuchae is difficult and often disappointing. In early and soft papular lesions, we may use topical corticosteroids with or without topical retinoids, imiquimod cream, or pimecrolimus. In lesions that are hard or patients with nodular lesions, we may add intralesional corticosteroids. If we have evident folliculitis, we may give topical antibiotics like clindamycin, or we can use systemic antibiotics like doxycycline. Isotretinoin is also helpful in patients with evident folliculitis, and it may also be used if we have progressive disease with development of new lesions. In resistant cases, we may use cryotherapy, various types of lasers. If these fail, we may go for surgical excision, and finally, if everything we try failed, we may try radiotherapy. In all cases, after treatment, we should maintain therapy with topical corticosteroids, antimicrobial wash, and topical retinoids. Thank you very much.